for a few minutes while we enter all our participants. We thank you all for enormous support that you have given us in all the webinars before. For any queries or any doubts, please log into www.onlinedentistry.in. Dear candidates, do not forget to register yourself for the webinar at www.onlinedentistry.in. We'll be starting our session in just a few minutes. Kindly wait just 2 minutes. Once again, a very good evening, doctors. We are all here for the webinar, Oral Habits and its Early Management. Before we start our webinar, we'd like to show you a small introduction video of online dentistry. So here it is. Thank you, dear doctors. Our motto at Online Dentistry is to redefine dental education and take it to another level. Our numbers suggest that we had been established back in 2008, and the total number of offline classes that were taken are 122. So you're amazed, the total number of online courses that are conducted are more than 500. And we can proudly say that we are a global family of 20,000 people worldwide. Well, coming back to the mastermind, the grandmasters of online dentistry, that are Dr. Jobby Peter, sir, MDS, Professor and Head of the Department Pediatric and Preventive Dentistry, Anu Dental College, Head of the Academics, Online Dentistry, and Dr. Binuti Abraham, sir, Kerala Dental Clinic, CEO, Online Dentistry. Well, we all know online dentistry is never lacking in conducting a lot of webinars. So this webinar, which is coming up on 26th and 25th and 26th of September, is filled with lots of guest speakers. We all know that somehow we all were affected due to COVID. Our knowledge, our brushing up of a lot of topics were lacking. So now a new dental college, which is accredited by NAC with B++ grade, which is the highest for any single institution in Kerala, is conducting an amazing conference that is Horizon Unlimited, where we have 9 guest speakers that are internationally recognized coming up and giving all the knowledge they have on different topics. So ladies and gentlemen, do not wait. Click on the links below and register yourself because this conference is free for all. Coming to the most amazing session that is going to happen on public demand. Let me tell you, ladies and gentlemen, this session had been held 4 times, and 5th time after public demand, we are conducting it on 10th of October, and the seats are already filled. The seats are limited to 20. So do not waste any time and click on the links and book your seats at the earliest. Coming to the most amazing show that we are going to have, that is on 23rd and 24th of October. Well, this is a little different from all the webinars because this is the first offline program that online dentistry is conducting in the last year. Pandemic hit us all, we all know that. And we could not conduct any offline classes due to that. But due to the relaxation from the government and the betterment in the cases, we are coming with orthopedic movements. This topic is something that is untouched, a gray area. A lot of practitioners don't really go into that area to explore because it's not something that we can explore. We have to have a proper training and practice on this. So ladies and gentlemen, do register for this because the seats are already limited to 20 and we have only the digit number seats remaining. So the program is going to be held on 23rd and 24th of October in Kochi, Kerala. Do not miss this. Well, we have another session coming up, that is cases under general anesthesia. We as a dentist do have a lot of restrictions because of the area of the clinic that we are in. Have you ever thought about hospital-based dentistry? Have you ever thought about the patients who are apprehensive, who are not so cooperative, how to deal with this? Ladies and gentlemen, come to this very short session where we can have almost like an interactive session. You can ask your questions and Dr. Vinod S. Nair sir is going to answer them all for you. So you can make your dental practice better, smooth, and you can help a lot of patients to come into your clinic and take the benefit your own hospital-based clinic. Well, without wasting any time, I'd like to inform you all that if you have any doubts, any confusion, or if you want to stay updated, please message us on this number or log into www.onlinedentistry.in. Well, coming to today's session, oral habits and their early management. We all know habits is a day-to-day word used for us, but we as a dentist know what repercussions, what consequences habits has on a child. And if that goes misdiagnosed, a lot of consequences have to be dealt for the child, for the parents, as the dentist as well. So we have Dr. Joby Peter here to decode that all for us. Well, I welcome Dr. Joby Peter, sir. It's my privilege to be announcing him here. I would like to give a small introduction to sir, that is, sir had graduated from Manipal College of Dental Sciences and pursued his post-graduation from Rajamutaya Dental College, Annamalai University, Tamil Nadu. He holds a PG diploma in criminology and forensic sciences. He has also got a certified training for tobacco intervention initiative from the prestigious NIMHANS, Bangalore. He is a member of various associations like IDA, American Association of Pediatric Dentistry, and has been a guest speaker at various international conferences worldwide. Well, adding a feather to his list, Sir holds the LIMCA, Asian and Indian Book of Records for traveling 10,000 kilometers in 23 days, covering 13 states for a noble cause, Tobacco-Free India. Sir, it's my privilege and honor to be announcing you here. Ladies and gentlemen, Dr. Joby Peter, sir, on your screens.
Thank you so much, Dr. Devika. Are my slides are audible?
Not audible, sir.
Am I audible?
Yes, sir, you are audible. The slides.
My slides, Dr. Joe, my slides are visible?
Yes, sir. Your slides are visible, sir.
Yeah, fine. Can I continue?
Yes, sir. Please go ahead.
Thank you so much. Thank you so much. This habits, it is being repeated multiple times, multiple college. It's been done, but due to public demand, many of us asked, sir, can you do this program once again? So as part of that, we are doing this program. Thank you so much for showing interest in this program. And I hope everybody is safe and sound in your respective place. So we are coming up with multiple programs. Stay tuned, never miss varieties of programs which even you can't think about it. The scope of dentistry is ever changing, and today's program is also so important in your clinical practice that a simple change that you give to your patients, it can be a child, it can be an adult, believe me, that can change your practice. So welcome you all for this a very small group where we are going to have more of clinical discussion and interactions there. I just want to ask you one question. Do you know that when you open your mouth and sleep, I'm repeating it again, when you open your mouth and sleep all through the night, which you can snore or you sleep or whatever, when you do that, you are prone 3 times to a disease called diabetes. There is 5 times increase chance of getting cancer and 15 times sleep disturbed person 15 times higher chance of meeting with a road accident. This is not done by me. This is done by CDC, and they have found out that there is a correlation with sleep disturbed or sleep disorders, we can say, and 3 important things can happen with this kind of persons there. So now we are all practitioners. We have patients from very young age, adolescents to adults. Is it important for a dentist to attend a webinar on habit? The signification comes from here is this studies clearly shows that there is a role in every disease that is happening. There is a role. Either it can be a minute or it can be a very relevant role for a dentist. The reason which I said this is not said by me. Many more years before, there's a very famous proverb, a Chinese proverb. If you are considering holistic, or if you are considering whole body, where the beauty, the skeleton, the muscle, everything is together, whole body of a person, if you are considering, a disease enters through the mouth. Now, who is the one who dealing with mouth? It's not an ENT, it's not a surgeon, it is dentist. We are the one who's dealing with the mouth. And that is the pathway for disease to enter into your mouth or to your body. So don't you think that question is been asked? Oral cavity is the mirror of your body or mirror? Yes, it is oral cavity. So that signifies what I said. Habits, many habits which happening in and around our mouth has got an impact, and we dentists should have a clear stipulated format to break this. Again, I'm telling you, because I am a general practitioner, a pediatric dentist into 22 years of practice, we only try to see very limited amount. If a patient says that my son or daughter opens the mouth, we only see how to close that and finish it off. If they say a tongue thrusting habit is present, we only see how to break that and finish it off. If it is a thumb sucking habit, let me break that somehow and say that, I broke that habit. I'm the best. That's it. We never ever think what this habit can do to the entire body of the patient, entire psychology of the patient, entire family. Have you ever thought about it? Because 3 habits which I'm going to discuss now and today is not just dentist did and broke the habit. It is like you broke the habit, you were successful, but at the same time, holistically, you have taken the entire family with you. You have done an amazing change in the entire family. Believe me, I started breaking a habit of a child who was 7.5 years of age. And when I did that, the father came to me, Dr. Joby, please, I want to talk to you. I said, what happened? I have a habit. I want your appointment. Wherever you are, I will come, but I want to talk to you. I said, you come to my clinic. He came very far. He came, we discussed, and I'm treating him of a habit. That is the importance of habits and its management. Think beyond what you and me can do into your daily practice. That is dentistry. That is the scope of dentistry. That is the amazing part. Dentist can touch every field if you are trained, educated, planned, motivated, applied clinically there. Welcome to my college, Anu Dental College, which has been accredited as B++, principal sir, chairman sir, everybody. You are all welcome to my college anytime. Rahul and Nivedita got married. Both of them got married in 2012. Within a year, they got a kid. And after a 1.5 month, when they have the beautiful child with them, she had to fly for her job. She got a call that you have to join, you have got an opportunity, you have to join, otherwise you will miss it. So the demands. She went. 1.5 to 2 months old child, she has to live because that's survival. So the child was, Adit was left with Rahul. He took care of it. But this is not an emotional story, or many people might have felt, has seen and heard about this story. But I want you as a dentist, which phase, ask yourself, which child development phase of this is deprived, or what do you think which was not happening? Can you come to the chat box and say which phase of Adit? I just want to see the chat of Adit is deprived. Anybody who's listening to me, can you put in the chat box and say either in YouTube or the which phase of development of this child was deprived? Great. Suckling, oral, yeah, breastfeeding. True. You are done. Any more? So, oral, yes. It's very true that Adit have deprived of the oral stage of development because her mother has to move, or because of that issue, she has to go, and he was deprived of that stage. So what has happened is he got something like this. What is that? Something like this he got. Yes, you have said the oral stage of development is deprived. Or he was not happy with that. So he started getting more. You have the basic human instinct. That was not satisfied. So he started doing something called thumb sucking. Yes, thumb sucking. I'm getting the answers now. Fixation. He got stuck there. Thumb sucking. He's 9.5 years now. They both came back. The job, everything is done. Corona is done, everything. They came back, and the problem is that he is having a problem called thumb sucking, and they are worried. They are worried because this is the status now, 9.5 years now. So what can you do with it? You tell me what, as a dentist, you will do at this point of time. Can you put on the chat box? Please come to the chat box and put what you will do it. 9.5-year-old child come with a complaint, a thumb sucking. The child will never say, I'm sucking the thumb, but the parent says that this. What will you do? Interception? Yes, correct. Anybody else has got any more? Break the habit? Yes, you need to break the habit because it's not normal. Habit breaking appliance? Good. So answers are pouring out. Yes, I need to break the habit. Yes, that is still he's continuing. So at least you understood one basic idea that this is not normal. 9.5-year-old child with laterals erupted with such a huge open bite. It's not normal. So I have to break it. Yes, habit breaking, gut. Interception is required. Now, this is exactly what it is being applied to this child. He was given first this, a removable habit breaking appliance. It did not work. Then the dentist gave a fixed one, but even then it didn't work. Parents are now coming, now telling the history, saying that, doctor, we tried this, we tried that, we tried this, everything we tried, but this fellow is keep on removing the appliance, one side getting loose, both sides coming out. It didn't happen there. That comes the importance of this. What is a habit? Please, we dentists should understand what is a habit. Now, I can put definitions which are standard recommended definitions, but I'm going to put those three most important definitions. If you want to pass an exam, you should know this definition, but read these three definitions given by three authors. They have one common or golden thread. In these three definitions, there are common thread that is happening. So you can hear this word frequent, constant, repetition, learned pattern. Some kind of things are very common in a habit. So something like this, a constant, frequent, repeated, acquired, learned. So habit itself is a culmination or a combination of constantly this happen or frequently this happen. It is repeated multiple times. So frequency and repeated multiple times. It is acquired. It is not inborn, acquired, or it is learned from the nature. The nature forced the child to learn. So that is the basic things that you need to know. One part, it is being acquired or learned, repeated constantly, many times it has been happened there. That is what habit is about. Now, when I talked about all those things, you should understand that our brain is an amazing structure. It seeks pleasure, it seeks gratification, it seeks comfort zone. If you are comfort, elated, gratified, it's so happy it is. Anything that causes that, give that mood to our brain, it will continue to do that. For example, any smoking helps somebody to do that, brain will ask or crave it to do that. Alcohol, ask and crave to do that. Some people want traveling, will ask the brain, oh, when I go for a ride, I'm relaxed. So that is what our brain does it. That's a one particular thing for our brain. It wants soothing effect. Anything which soothes it, it will try or force us to repeat it again and again so that it can get soothed and relaxed. It doesn't want that stress and anxiety. So for this child, the soothing or the comfort zone was that oral area, fixed onto that oral area. So anything that fixed onto that area soothes the brain, and brain tell them, do it, you continue, we are happy. And he resort to that. So there is a pattern running here. From that oral area, there's a pattern running one after the other, which soothes the brain there. And they're happy. And that is the importance of this study. They did a study and said that if a person, a child, repeats one particular things for 300 times, it makes a habit. It can be a lip biting, it can be anything. If a person repeats 300 times, the brain registers there and it becomes a habit then. I'm not going to pathophysiology or how it happens, but this is what they found out there. Be with me at the end till the last slide. You will understand how many repetition, how to break this. So it can be a thumb sucking habit, it can be a lip biting, it can be a nail biting, it can be a tongue thrusting, it can be a smoking habit. You repeat it, it becomes a learned pattern or behavior, and the brain will register it there. So brain will do that. That is not our part. Now come to a dentist part. What are the effect? What dentist should be more alarmed or informed or equipped or should know more about this habit? The dental changes or the skeletal changes we can take with this habit. That depends upon, can anybody come to the chat box? The effect of this, any habit it is, depends upon what are the factors that determines the change in the dental skeletal effect on a patient. Can anybody come to the chat box and say, yes, what are they? What are the dental changes due to any habits depends upon mental states? No, okay. Akshat said intensity, fine, only intensity, muscular forces, whatever, fine, fine. Anybody else has got any more? Intensity, frequency, duration. Okay, that is by Dr. Madhubala. Dr. Madhubala, congrats. You said that intensity, frequency, duration. There are three important things called intensity or frequency. Frequency means how many times the patient is doing. Duration, how long in a day or totally how long it has been doing. And lastly, the intensity, how vigorous it is done. Now, can anybody come to the chat box and tell there is one more factor? One more factor. Can anybody? There is fourth factor which is also important for dental and skeletal changes. Can anybody think about one more factor that can cause the changes in the one time, age? No, not that, not that. Anybody? Anybody? Time, age. I'm getting a lot of response. Anything else? One more factor is there, which we have missed actually, but it is there. Anybody? Fine. It's none other than direction. Direction of the force exerted. That can cause proclination, that can cause retroclination, that can cause open bite, it can cause things. So this is important in our diagnosis part. A frequency, duration, intensity, and direction of force, because that one gives that open bite, skeletal growth, the vertical growth, that cross bites, anterior, posterior, so many things, that proclination, everything depends upon which direction the force is going. And what do you mean by the force? The force can be from the tongue, the force can be from the tongue, the force can be from the lips or the perioral muscular. That can be the force. Which direction the force is being exerted more, the effect will be visible in the patients there. So our clinical diagnosis, we have that screening form. It's very important. That tells, okay, this patient force is going in this direction and he has got an open bite. Because of that open bite, things have changed, faces, everything is changed there. So direction of force because of the thumb or tongue or the mouth breathing that is happening is very important to analyze that. So let us come to the first habit, thumb sucking habit. One of the habit that we least understood in our practice there. Why I said least is, I just want to ask one question to all of you. You might have come across with people or child or adults doing thumb sucking in your clinical practice. Definitely you might have come across. Now, one thing I just want to ask you is, have you ever thought about the mind of a thumb sucker? Have you ever asked that person, why are you doing this thumb sucking? Why are you doing it? Have you ever asked that? If you ask in front of the parents, in front of everybody, he won't tell. But just have a close interaction with the child and ask them, why are you doing this thumb sucking? I used to get message, I love it. I feel hungry, so I do it. I feel insecure. I feel lonely. I'm tired. I'm secure. So many questions, so many pops up come from there. What is the significance of this? Our treatment planning depends upon this with age of the patient, which I'm going to discuss there. So a person who's doing thumb sucking, believe me or not, is like in a deep hole. He just enjoy, he makes a frame of himself and he want to be inside that hole. He don't want to come out. It's like a deep inside a well. I'm there. This is the world. This is, I'm secure. I'm happy. Nobody's going to hurt me. This is my comfort. This is only way that I can be secure. That is why he is resorting again and again back into that. One patient, I really asked him, why are you, I feel hungry, so I do that. So why don't you take some water? That is what the patient feels. Think about from the patient's point of view, what they feels of doing this habit. So they are actually closed. They want help. And we dentists are the only one who can really help it out to come out of that thought of being inside that well. We can really take them out. For that, you have to discuss things. That comes the importance of this. Can you please see this two thing that is happening here? There's one picture, one is a child is feeding on the mother's breast and other child is speaking on the thumb. Can you tell me the difference between these two habits? Can anybody tell me what is the difference between these two? Then what I've told before will be more understanding. What is the difference between these two pictures? See, one picture is a natural process that is happening. Yes, nutritive sucking, exactly. One is nutritive sucking. That's a natural process that is happening for a child and he gets that at the right time and he does that. And other one is a non-nutritive habit, non-nutritive sucking habit. That is not related to any nutrition, anything. So there is somebody, something he want to satisfy. Here, he want to satisfy his hunger. Here, imaginary hunger or imaginary illusion he want to satisfy. There is no nutritive sucking habit. And the problem for dentist is it is 4 times more malocclusion non-nutritive sucking habit can cause. 4 times more compared to nutritive sucking habits. And this is a study, you can see that it almost 4 times more dangerous to the dentition there. So you can divide sucking habits, the thumb sucking habits into different category. Type A, where the entire thumb is inside. Type B, C, and D, different depending upon the different position of the thumb, different position of the thumb inside, and the contact between the upper and the lower jaw. You have A, B, C according to subtly is there. And the most dangerous is A, because the direction of the force, because in A, the child keeps the thumb inside and push against the palate and anterior teeth, and it causes more damage onto the dentition and the skeleton there. So there are different classifications are there. You please read about more of that. That's not the point of the, you have different types of thumb sucking habit there. And then what you call for this. See, my point is here is whatever the classification says that it's got a different thing to do it. But in a clinical practice, we need to break any sort of thumb sucking habit. Now, how will I take a decision? Should I break it now? Should I wait it? What approach should I do it? How should I break it? What follow-up should I do it? You should be able to clearly plan it before doing it. If you take a textbook, you can get a thumb sucking habit. You go to refer, okay, this. You will get that is not possible in your clinical practice. How we have to do it, we should know. So the effect of thumb sucking, as you all know, it causes varieties of dental and skeletal effect. It can cause an anterior open bite. It can cause a lingual positioning of the lower, labial positioning of the anterior. It can cause a unilateral crossbite, bilateral crossbite, anterior crossbite. You can cause a varieties of malocclusion with this thumb sucking habit there. And extraordinarily, you can find that callus, which is very hardened on the thumb of the child there. So you can have open bites. A thumb thrusting habit can cause an open bite, and it can lead into a tongue thrusting. It can even lead into a mouth breathing also. So you can see a chain of reaction happens just because of one thumb sucking habit. The current approach of treatment of thumb sucking is mechanotherapy. Whenever you see patient, that's what you said. I asked the question, you said break it with habit breaking appliance. So mechanotherapy is the one. Or let us wait till 13 and 14 years. You know, orthodontics can do an amazing, the open bite can be closed, intrusion mechanics can be done, extraction philosophy can be done. So many things can be done. Don't worry about it. That's another approach there. So let us tell you how we can approach it holistically is you need a screening question, understanding the child, understanding the parents, their family background. That's an amazing chart. Dr. Binu will explain the upcoming programs. There is an amazing way to find out how we can holistically break this habit. A 24-hour should, it can really blow the patients out saying that, oh my God, so many things are there. For the first time in their life, they feel, oh my God, I did not go for a vacation for a long period of time. Oh my God, my family. So many things could be the reason for that child is being deprived or being stressed, neglected, avoided. You never know. So you need a comprehensive treatment plan to treat a thumb sucker. It's not just an appliance. You just give some appliance and everything is done. My matter is done. As a dentist, it may fail many times there. So what is the right way to do intervention? Could be a psychological way. There are so many methods and ways you can mold the parents. When to mold the parents, when to mold the child, or when the psychological approach has to be applied for parents, when it has to be given. Can you tell a 4-year-old child you do psychological approach? You cannot break that habit from the child. That is the time that you should attend the parents. Have you missed that? That is why that screening is very, very important for us. Counseling. 3-year-old child, can you counsel it? 4-year-old child, can you counsel it? No way. When to start counseling? Which age group children you should start counseling and what you should do? From where you should start? That screening form, habit screening form is so important so that you can start. I should start from parents or I should start from child. Sometimes we ignore the child. Child, no, you enjoy it. You do it, no problem. But our focus is the parents. Focus them. So that one part is very important for the reward systems and reminder therapy and mechanotherapy comes there. So right way to approach will be from the psychological to counsel, but which one is important. So child is very important, and the parents and the dentist, we should work as a team. That amazing protocol is very important to get success in breaking habit. And 90% of the habits of thumb sucking can be you can break this without any appliances. You can easily break it. Appliances are the last resort or the adjunctives to sustain on recall visit there. Otherwise, you can easily break this thumb sucking habit without any appliance therapy there. So treatment protocol, if you saw, 1 to 3 years observation, regress by itself when they go to school, that they have an urge fixation of suckling this, that you cannot deprive for a child with that. So here you should concentrate on talking to the parents. What you should talk, for that you need a screening form where you will get where the parents are not concentrating on to the child. That is very important. And then you start talking, parents will, oh my God, Dr. Jovi, I never ever felt like this. You really opened our eyes. I never spent time. So you really opened our eyes. That's a good move that you can do. Talk to the parents there. 3 to 4 years, you can use this bitter tasting things are available in online. You can do that. Or another thing is you can even, so there are some textbooks are available which tell stories, and famous character stories are there which child can read. And that this younger child, you can read to this them, they 3 to 4 year old will listen to them, and they, oh my God, it's not supposed to be done. And there are many books are available in Amazon or in Google is available, and famous thumb, bear thumb, so many things are available. So the child get attracted to that and they might discontinue the habit there. Or even you can try about this band-aid system. You can try where famous cartoons characters are also available. You can do that. Or an observation, psychological counseling can be done. Here you have to talk to the child. Above 5 years, now we are shifting the focus from the parents. We are shifting the focus to the child. Talk to the child comes very important. And once they are ready to break this, you can use things like a micropore tape, you can thumb guard kind of things, you can do that. Or reward system is again important. Rewards, how many days in a week, one day you broke, you give a small gift, 2 day bigger gift. So those kind of things can work out. An amazing session with Dr. Benu, who talks about how to talk the thumb out. You are not talking to the child, but talking to the thumb, then talking to the child, then talking to the parent. Talk them and make them stop this habit. And that's one session you should listen to and attend that. So if the parents say the child is elder, like 6 to 8 years, then comes your conventional therapy is there. So we will wait. From here to onwards, you need assistance. You need to talk to the child properly, understand deep-rooted problem has to be addressed, and take the confidence of the child, and then start giving these appliances. Like so many appliances are there where you can get, so many other extra reminder appliances are there where you can apply it and try to break these habits there. So this is not your first line of treatment there. So when you talk about thumb sucker, find out the age of the child, frequency, intensity, and duration of that habit that is happening. If it is under 2 years, leave it. Talk to the parents. Tell them, give them more feeding if it is possible. Spend time with the child possible. 3 to 4 years, you can home remedies can be applied. Something band around, all those things can be applied. 6 to 8 years, that is, you are talking a deep-rooted problem. If you have a child with that, then definitely you need that tongue screening form, the thumb screening form, which tells you what is the reason for his habit, what is a deep-rooted psychological problem of him. You attend that first and then come to reminders. You will get a good response there. So there's one solution that has come in WhatsApp is that keep the child's thumb busy. Whichever thumb he's sucking it, keep him busy on that side so that he don't have to suck the thumb because he's busy with that. Exactly the same thing. Make the child more active, engage in more activity. You will be able to break that habit. But for that, you need to understand things which I already told you: age, frequency, and intensity, duration, the parents' counseling, and the child, the situation, the screening form is very important to analyze what is happening there. So if 300 repetition makes a habit, let me tell you, 3000 repetition is required to break that habit. That is a problem with the thumb sucking habit. It's not easy to break it. Some habits are easy. Some children easily leave it because you approach the right age with the right approach. But some deep rooted habits require more stress, and your follow up is required for that. So you need a plan for those kind of habits to be broken there. So everybody, it's just a fun time. I know I'm talking, so this is just a fun time. And what is that fun time? Habits, habits. So can you come to the chat box and tell and write down maximum number of words you can make with habit? You rearrange it and make maximum number of words and put it in the chat box as one shot. Please put in your chat box as one shot, maximum number of words with habit. For example, I can make it, I can make is. There's two things I've told you. So please do it in the chat box. Maximum number of words with habits can be made. Fine, fine. So many words are coming up. Great, great. Even I have not thought about so many words. Sat, had, hit, bit, bits. Good, 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 good. Keep on going, keep on going. Oh my God. Nasviha, she has said sit, bit, tab, bat, his, has, sat. Oh, great, great. That's good, that's good. You have 30 more seconds. Let me see who will give the maximum number of words in one shot with habits. Done? Fine. 30 seconds done. So I think Dr. Nasviha, Dr. Nasviha, you have set the maximum number of words, around 10 to 12 words you have set. Congratulations to you. It's a sit, bit, tap, bat, his, has, sat, hat, and hit. Good. Yes, I'm just going to put a picture. This is a video. What is happening here? Can anybody tell what is happening here? What type of habit is the next habit where you're talking about? Is about habit called tongue thrusting habit. So if you identify a patient is having a tongue thrusting habit, what will you do? That's a another very common scenario that you see in thing. How will you break this habit is the next habit. Directly, let us go into that habit called tongue thrusting habit. What will you do there? So conventional approach is give a fixed tongue guard or removable. That is not very productive, removable tongue thrusting, but a fixed tongue thing can be, fixed tongue guard can be given. But the problem is, you can see this is one of our patient, one of our candidates who have done this and asked, sir, I did this appliance, but it doesn't work. You can see why exactly it doesn't work. You can see the tongue is going below, or the child is opening the mouth and nicely following the habit again with the crib there. So sometimes you can see the crib comes out whenever you give this fixed or removable crib, it always comes out there. So what is the reason for this tongue thrusting habit? Have you ever thought about it? One of the most common reason which has been documented in the literature is early loss of anterior teeth. Like 4 anteriors have gone to the ECC, could be one of the reason. Another most common reason is prolonged bottle or breastfeeding. So the child doesn't develop mature swallowing pattern, prolonged breastfeeding, or habits like thumb sucking, which can cause an anterior open bite gap between the teeth. So child will keep the tongue in between there and start developing there. Mouth breathing habit, again, the child cannot close the mouth, open the mouth, so he develops forwardly placed tongue. So tongue thrusting is a forwardly positioned tongue in between the upper and the lower teeth. So this is one of the reasons that can or an abnormally large tongue called macroglossia can also cause tongue thrusting habit there. So what does this habit does to your patient there? It can cause an anterior open bite, unilateral or bilateral posterior crossbite it can cause, and crowding it can cause there. So open bite it can cause, it can even cause proclination of the anterior, can a crowding it can cause bidental or skeletal proclination it can cause class 2 div 2. That kind of patient also you can have tongue thrusting. You can even have a typical class 3. So tongue thrusting is in the literature is a very common. 99% people also can have tongue thrusting in one form or other way. So here comes the importance of a dentist saying that tongue thrusting can be seen in any patient, and you have to identify my patient has got a tongue thrusting before a full-fledged orthodontics. If you are doing a pediatric patient, interceptive orthodontic, if you are doing, or expansion or anterior crossbite correction, anything if you are doing it, it is your responsibility to find whether my patient has got a tongue thrusting, because literature says, one Brazilian article says 99% of people can have tongue thrusting. Children can have tongue thrusting. So tongue thrusting can be either hidden or it is very obvious. When you see an open bite, it is very obvious. Plus a class 2 div 2 patient can have a tongue thrusting. How will you identify it? Because there is no open bite. So how will you see this? That is comes the importance of diagnosis of tongue thrusting. A bite under proclination, fine. Okay, proclined teeth, you see, it may fit, but there is no open bite, but still, is the tongue is thrusted while swallowing or function, how you come to know. So currently what happens is your orthodontic mechanotherapy can exactly correct every malalignment, open bite, class 2, div 2, everything can be done, but tongue is not addressed there. And the end, we will end up with fixed retainers there, just to hold the tooth at that position. Even though tongue comes in between, it doesn't move there. But these retainers also doesn't last for a long period of time because of this. The reason is the tongue can exert up to 500 grams of force when you do the function of swallowing, and you require very little amount of force for a tooth movement. A gentle force is required to do a tooth movement there. So tongue exerts a huge force, and you need to identify whether the child or the patient, whomever you're treating, has got a tongue thrusting is present or not. So that comes to the point that what is tongue thrusting? It is just mere placement of tongue between the upper and the lower lip, or any other thing is need to be identified, comes an important thing, because tongue is actually caged inside your mouth. It is the circumference that the tongue get is your mouth. It's a framework there. So it's like tied there, like a 6-foot tiger in a 3-foot cage. So the entire patient's arch is what tongue can move. How much it is available, that much only tongue can move. If it is less, tongue will have to adjust it, because it's a muscular organ. It can adjust, it can go back, it can come front, it can do anything. So whatever perimeter that arch allows, and tongue will adjust according to that. So it is like a tiger, powerful tiger inside a cage. That's a famous book written by Felix Leo, who said that's a 6-foot tiger in a 3-foot cage. So that is one thing that we have to assess before starting tongue thrusting habit breaking. Please don't give appliance first. Assess it. Tongue assessment, tongue mobility, tongue motility, the entire arch of the patient, the muscles, what is happening there? We need to assess that before starting an appliance, because this is a tiger, and he will come out. He will definitely come out at one point of time. Don't think that your crib will help him. It's not going to help him. He will remove it. The most example, let me tell you, is sometimes we give Quad-Helix. And if you do not assess the palate architecture, or if you do not assess the tongue posture of the child, the Quad-Helix will be out every week. We have to refix every week. So that is what I'm talking about. This tongue crib also, if you give, it doesn't going to stay there because of the tongue and the architecture of the palate, the availability, the mobility that tongue can do as a muscular organ should be given sufficient space there. So if you want to break tongue thrusting habit in any patient of any age group, you need to identify the type of tongue thrusting there. Functional assessment, screening for tongue that you can't get anywhere. I've compiled around 30 parameters to be checked for a tongue, and that will give you functional assessment of the tongue, and then tongue exercises. Now people started doing tongue exercises. They see the oral gymnastics. Many people ask me, give me the article. I am sending the article. They started doing it, but not successful, because there is a right way to do a protocol there, and that can give a lot of good results there. So, and the last one is the appliance therapy. So tongue assessment, a screening test for tongue, which is the most elaborate one, let me tell you, where you assess the tongue, you assess the position, function, form of the tongue, even the soft palate, even the Malambetti classification also is very important. The frenum of the tongue is important. So much thing, tonsils also, in grading of the tonsil. You as a dentist should know, we are dealing with that. The tonsil, how big it is, how small it is, you should know. The soft palate architecture, is it constricted or is wider? If you want to wide, you have to make it wider. All those things is very important. Just giving a crib in a constricted arch with a grade 3 tonsil and Malambetti classification, you can never become successful in that practice there. So, and exercises, airway analysis, cephalometrics is very important to see the airway space that is available for this patient is very important for tongue thrusting habit. And one thing is tongue tie. Please see the size, form, and function, and tongue tie is one important thing you should always assess before giving any fixed or removable crib there. So with this this assessment, you will come to know whether you have a simple tongue thruster or a complex tongue thruster. A simple tongue thruster, you will get a feel that there is perioral muscular activity which are there, occlusion is present, but the elevators of the muscles are not active in simple one. But in complex, all three will be active there. Perioral muscle, your elevators muscle, facial muscle, everything will be active. Little difficult to break, and you need more of muscular exercises for this compared to your simple tongue thruster. Even if you give a crib, it might work sometimes because that child or patient is luckily fall into simple tongue thrusting disease. But complex tongue thrusting require more of muscular exercises in order to train, and you need more of assessment for that. So how to train the correct tongue posture? You start with the sport exercises. First, identifying, making the patient to understand where to keep the tongue. So where should be the tip of the tongue should be resting onto a spot which is around 5 millimeters behind the midline. That is almost your incisive papillary area. That is a spot where the tip of the tongue should rest while you swallow it. So if you have any doubt in that, what I'm talking about, what the simple exercise that you can do is try to swallow. Just try to swallow normally without any conscious effort. Try to swallow. If your tongue tip is at this area, at the spot area, if is your tongue, that means the tongue is at the correct posture. And you try to swallow, you can see that you are swallowing it properly, and no much perioral muscular activity, and your occlusion will be there. Posterior teeth will be in occlusion. That is a normal swallowing pattern. No facial muscles are active. Only the elevators of the mandibles are active, and you have occlusion. So that is a normal swallowing. So if I swallow it in front of you, I'm swallowing, I'm going to do the swallowing without any conscious effort. I'm going to swallow. You can see no perioral muscular activity. Only the elevators of the mandible are active there, and I got occlusion in the posterior. That's a normal swallowing pattern. So to train that, you need the child to keep the tongue where. So you have to start that exercise there, the spot exercise. Keep the tip of the tongue at the spot and swallow there. So the spot exercise is the one thing that you should start. You should train. You should tell the child this is the area where the tongue has to be done. Keep the tip of the tongue there, tip of the tongue there, tip of the tongue there, and swallow. No much perioral muscular activity. The patient swallows there. Once the patient identifies that, we go on to tongue click at the spot exercises. 10 seconds the patient can do. Keep the tongue, keep the tip of the tongue at the spot and do a click, a pressure and click and swallow. So touch the spot, put the pressure, do a click and swallow. The patient has to swallow 10 times to 20 times. They have to repeat that. So once if they know where to keep the tongue, there are so many other exercises, but let me summarize it. When they know where to keep the tongue, then you can go. If they're doing it well, no perioral muscular activity, then it's the appliance therapies which we have told are all a reminder therapies, just to motivate the child, just to keep it holding. You require a minimum 8 to 1 year this appliance inside the mouth of the patient to remind, so that continuously is doing it. It's not easy. Once 3 to 4 months will be your tongue exercises. Once the patient does the tongue exercises, just to keep the patient reminded, you might have to give an appliance like this so that child reminds it and it continues this habits there. So these are like intra or reminder therapy for those people who are in the end stage or towards the end stage of tongue thrusting habit breaking appliances. So every time when the patient come back, you have to check for it. Check for any perioral muscular activities happening, tongue is where it's placed, and how the patient is doing it there. So to do this, you even have to give some liquids, water. One of the best thing you can ask the patient to drink water. When the patient drink water, observe it and see the perioral muscular activity. Even you can ask the patient to have a syrup kind of things, little more thick milkshake kind of things. You can ask the patient to and see whether perioral muscular activity is happening or not. If nothing is done, that means the patient is keeping the tongue at the right posture and doing the right swallowing pattern. The mature swallowing pattern is happening there. So again, it's a fun time. You have E, F, G, H, I, J, K. So can you come to the chat box and make maximum number of words with this alphabets? I'm done. The last habit, I'm done. So can you please make maximum number of alphabets with this words E, F, G, H, I, J, K. You have to put in one chat. Okay, hike, fig. What about high? Is it possible? High. Fine. Yeah, high. Anything else? If he, I'm just giving you words. Fig, fine. Fig, kite, high, if, he, fine. Dr. Maria from Caribbean Islands. I hope it is, I don't know which time it is now. Fine. So fine. So that is done. Great. Just to break your mind about this. So 2 habits we have discussed: thumb sucking and we have discussed tongue thrusting. Next, Nivedita is just a 2.5-year-old child. She was perfect. She used to sleep well. Everybody was happy. She was almost 2.5 to 3 years of age. At that age, her father brought her a gift. That is a kitten. And she was so excited with the kitten. She was seeing YouTube videos of the kitten and then the cat video, cat lovers video. She got excited and she told father, I want. So the next birthday, her father bought a kitten. She was so happy. She used to play with her, sleep with her. That's like a best pal and friend. It went on, everybody was happy. But what happened is after 2 3 days, she started getting running nose, a cold. That okay, maybe the weather, they think about it. They never thought about the kitten, and it started increasing, and she started getting upper respiratory by around 4.5 to 5 years. The upper respiratory frequent tonsillitis, blockage, and finally she had to use even steroids to breathe. Just started with that, but nobody knew about it with that kitten. And now she's around 8.5 years of age. The parents, new teeth started coming out. So 8.5 years, new teeth started coming out, and they are crooked, and they are worried about the crooked teeth. They were just don't know about the kitten. They don't know every child is having cold, every child is having the problem. So they did not worry about it. They are not worried. Pediatrician told, everybody told it's a normal thing is happening, pollution, this, everything they did. So they continued. But when the new teeth start coming out at the age of 7 to 7.5 years or 8 years, the mother got worried. Oh my God, this is not good. Let me meet a dentist because teeth are crooked. So I have to meet a dentist. So she came to meet a dentist. They met a dentist and said, she's a mouth there. She opens the mouth every, oh yeah, she opens the mouth. So, okay, she opens the mouth and teeth are crooked. So the solution was this one. To break the habit, what you need to do? Mouth breathing habit. With the textbook says mouth breathing habit, you have to do an oral screen or a myofunctional appliance or whatever it is. So the dentist made an appliance like this to her. She was been using it, but no improvement. And then they came to us for a second opinion that things are getting worse, no improvement, and she can't wear this appliance. Tried multiple times, but child cannot wear this appliance in night. She removes, or always in the morning the appliance is out of the bed. So there comes the point of another habit which we have least understood: screening question for mouth breathing. This can change your practice, let me tell you. So we did that screening, complete screening for a mouth breathing. This is a short thing I've told, but when we asked the question to his, the mother was saying, everything what you ask is present in my child, but nobody, even the pediatrician, never asked this kind of things. They just give me spray, they just give me nasal drops, they just give to me some antibiotics, some decongestant, Vicks, all those things. That is what they did. But no dentist has asked me this kind of question. No doctor has asked me this question. When we ask this, everything is happening daily, and they know it is happening there. So that mouth breathing screening, this is just a part of, I said, it is done with her. There are so much symptoms that is happening, which is very evident. As a dentist, we look into the inside and outside of the mouth of a patient, and so much symptoms of a chronic or a typical mouth breather is happening for her. From front, from side, nobody does it. Only dentist does that. We look from front, from side, extraorally, intraorally, detailed things we see that, which are all evidence of a chronic mouth breather inside of the patient. The palatal architecture, depth of the palate, the shape of the arch, so much things are there which a dentist has to look when you talk about a mouth breather. Indicators of mouth breather. It's a very important thing that you need to see that. So is it a screen, oral screen is going to prevent all those things? No way. So what we need to do is, first of all, no appliance therapy. Any patient whom we identify mouth breathing, no appliance first. I tell them to do a lip seal exercises. Tell them to seal the lips. I gave them the thing or ask them to buy the Surgiport tapes and ask them to do these exercises. Report to me with a chart. Let me see how your ward is performing it, can breathe through the nose when the lips are sealed, how long. The report back says that yesterday also tomorrow one patient is coming, said not more than 1 minute my daughter can sit with lip seal. So come to us, we can treat it. So that is the first thing that is been done. So once it is done, I know that either it is a habit or there is some real problem is there. We have to take a help from a multidisciplinary point of view. We don't know. I cannot do an endoscopy. I'm not eligible to do an endoscopy. So I have to take a help. I refer specifically with the report. I refer to an ENT, tell ENT that my patient, 1 week, 2 week, I tried with these exercises. She can't sit not more than a minute with lips sealed for a month. So please, I find something is problem with the respiratory nasal passage. Kindly check that. So they do a nasal endoscopy, find out what is really happening. It can be a DNS, it can be a polyps, it can be a adenoids, it can be a tonsil. You never know. They do that and tell. A report will be given to you, Dr. Joby. Yes, there is no problem. It is habitual. No, there is a problem. It's habitual. So I can categorize with the report that my patient is a habitually opened up, learned pattern. Habitually, it happened once. It all right, but patient is continuing. Nasal passage is clear, or it can be an obstructive, real obstruction still present there. Into that patient, if I put an oral screen or a vestibular screen or whatever, it will work? I don't think so. So that category, that classification comes to me. Now I can plan. What should I do? An obstructive need to be under an ENT. He does that and comes back. Habitual, it is in my fault. I can do that. So treatment for mouth breathing depends upon, once the cause is removed, then start with breathing exercises. And let me tell you that screening form, every 3 most common habits, we have the screening form which clearly tell you what type of thing is. We have learned this classification of habits in our theory exam, but now the application of that comes in clinical practice with this analysis, which no textbook gives actually. The screening question for thumb sucking, screening question for tongue thrusting, and screening question for mouth breathing. Separate screening questions are there. It is not just asking the patients, your son is having mouth breathing? Yes, son. Oh, okay. Then just give an appliance. That's a wrong way to do it. Or just telling that tongue thrusting, you just saw tongue is coming out, so I should, open bite, he said, let me give a tongue. No, that is not the right way to do that. That's not the right protocol. As a oral physician, you should be doing it. So exactly for the same thing, this will be done for this patient. Breathing exercises will be started, physical deep inhalation exercises. And again, let me tell you, I'm contradicting what I put. Breathing exercises we should start, but deep breathing exercises has got a pattern. You can't ask the patient to do breathing exercise. That is the wrong way of deep breathing exercises. Even in yoga, breathing or deep breathing doesn't mean that you take or inhale air in force. No way. It is not that. Deep doesn't mean that you forcefully breathe it. You take inhale or exhale it in longer time, but the pace is different. So that exercises are there. Then comes your lip exercises. To mold the lips, we have exercises for that. To make the lips, hypotonic lips, more active, we have exercises there. And those exercises, we have a chart. You can go to our website, you can get these charts, customized charts, your own clinic name, you can download it, add, give to a DTP, or if you tell us, we can even put your clinic name, and this is available so that you can give to the patients and they say, tick on to those days, how many times they have done, which day I had missed it. They will do that and they get the report back just to motivate the patients you can do this kind of exercises. So lip seal exercises, even I give pop sticks, I give them, or I seal the lips. Two things I give is, one is the seal with a micropore tape, or give a pop sticks. You can buy any your supermarket, you can buy this pop sticks are available. Buy that, ask the patient to hold this so the lips are completely sealed, and tell them to take the deep breathing exercises can be done. Then the appliances tug of war with your oral screen. You can do that exercises. You can tell the patient to do these exercises, tug of war exercises. Ask the patient to hold the screen, but you are trying to push it out so that the lips get the hypotonic lips get more tonicity without that. So that can be done. And pre-orthodontic trainer also not bad. That also can be done with the proper breathing exercises. Lip exercises can be done. So this are the exercises like monkey exercises, like you ask the patient to hold the air on the upper lip and the lower lip, like Hanuman. That exercises can be done. Ballooning can be done. Puffing air, tug of war, hold the lips together tightly with the screen. So you try to pull it out, all those exercises. And how long? 20 minutes in a day, which can be split it up into 2 to 3 minutes multiple times. You can do that with these exercises. So the same patient with the simple exercises, 18 months it took for me. Now she's 10.5 years of age. Almost 18 months it took me to break the habit and give her a good tonified lip there. And now for this patient, I am doing expansion because now the next phase has come. I need space for the canines. So I'm going to expand the high arch palate. I'm going to expand with a simple slow maxillary expansion appliances, which has been delivered around 3 to 4 months back. It has been delivered to her. This is a upper arch, and that has been done there from this to this. So to breathe of life, or all life on earth is breath. So let me tell you guys, we need to focus on our practice. Our practice, these 3 habits are the very common thing. Apart from bruxism, apart from the lip biting, most common practice that what we see is this one. And this can change our practice. Let me tell you, we treat the kids, but we end up with the adults, the husband, the wife, the grandfather we have treated because is happening to their home. The snoring, the bruxism, the sleep disorder, the tongue thrusting, everybody in the family is knowingly or unknowingly having it. Once we explain this to the child in a proper, meticulous manner with these things, these questions, when they see that, oh my God, I also have this habit. I also used to have this. I also drool it. They said, oh my God, even I am having it. So Dr. Jovi, can you, even I also have it. Can I come at another time to discuss with you these problems? That is what dentistry is about. So, a cat never does like a dog, but if a cat is being put into the group of a dog, even the cat starts imitating. Habits are the imitations or repetition, constant repetition that you are being seeing it, observing it. It can be thumb sucking, it can be other, whatever habit it is. So thank you so much. We are coming up with enormous programs, a varieties of program in online dentistry. Do not miss it. You can never get a platform where this arrays of programs are there. Like anything you can imagine, it is available there. So thank you so much. And you can contact me personally if you have any more doubts. And I'm just open for discussion. Over to Dr. Devika.
Thank you, sir. Thank you for such a great and extensive session about habits. I hope the cases that you showed has helped a lot of our participants. Can we start taking questions, sir?
Yes, doctor.
Participants are requested to put your questions in the chat box. So one question has already come up, that is, can we give oral screen to a 13-year-old child?
You can, doctor, but before giving it, I have again telling you, I have given even for 35-year-olds, I have given oral screen. But let me tell you, find out the reason of that habit that is happening, and then you can give.
Thank you, sir. Any more questions? Kindly please put it up on our chat box. Meanwhile, I'd just like to inform you that we have a very interesting and a full day session that is coming up on 10th of October, and we have limited seats for the same, and that is all about habits. So please do not miss that session and click on the links to register for the same. The next question is, what can be done for nail biting?
Yeah, I saw that question. Nail biting is a habit which is again, if it doesn't causes any kind of dental problem, it is not any kind of malocclusion. You do not need any treatment, but psychologically you have to counsel that patient what is the reason. It's a very deeply associated habit is a nail biting habit. Some people say that you can give that lip bumpers and all that doesn't work in a patient, but literally tell you, if it doesn't causes much problem for the dental features, you can ignore that. You can just constantly give some support and motivation. You can be given, you can be do that, and there are something like spurs are there. You can put it on the lingual aspect of that, which causes some injury onto the hand if it is done. So that can be tried. That can be tried to break that habit.
Thank you, sir. The next question is, if a child is having both mouth breathing and tongue thrusting, which habit have to be treated first?
See, both habit has to be taken care of, doctor. So it is the importance of that screening question which I have told you, which gives you, if both habits are there, you have to do the screening for both one. For example, if the patient says that, oh, my son, four anterior teeth are been removed or was like a root stem from when he was 2.5 years of age, that means the tongue thrusting possibility is first. That started and then it continued and came to mouth breathing. Suppose if the screening questions gives you a clear claim that he had multiple upper respiratory tract infections in a younger age and he started opening the mouth, then you got an idea of mouth breathing started. Whichever habit we started first is not significant, or whichever habit you're breaking first is not significant. What is the current assessment that you have done with your case sheets, with your screening question? Okay, he has got both habits. Now, let me try to break which one. You have that model analysis. See, imagine there are both habits are there. You try to give an oral screen. The patient cannot wear that oral screen because he has got a adenoid block or anything. So he will remove the oral screen there. Suppose you are trying to give a crib. The palatal architecture is such that high arch palate, narrow palate, you give that crib, patient removes it, tongue doesn't have space to do that. So you never know. So that is why a comprehensive analysis is done. You can break the habit once you know the script is there with you. So sometimes you will expand. You don't break the habit first. You will just expand because there is no space. That expansion might give a good round shaped arch where tongue can go and can be trained easily. At the same time, the nasal passage, when you expand maxilla, the nasal passage widens. So breathing also improves. So both habits, you can break in one shot. So please try to understand that it is not the habit is the one that you're breaking, is the condition that is happening in each patient is the one thing that you have to analyze. And for you, it's the condition that you have to take care. For patient, it is habit, but for you, it's a condition. Okay, I treated holistically and I broke both at one shot or in sequence, I did that.
Thank you, sir. The next question is, how to make parents aware for their child for early dental checkups, as in India, it's neglected.
Yeah, yes, doctor. That is one thing what we have done is how much time do you spend with a patient? In your first appointment, how much time do you spend? If I ask many of my colleagues or many of my very famous thing, they spend very less time. They go to clinic as a consultant or they just spend, okay, pulpectomy, they do pulpectomy and send it. this is what one I insisted on every clinic whom I go. I need a consultation appointment, which I spend half an hour time with the patient. Otherwise, I am not treating the child. And that works well for me in my this much years of practice. Wherever I go, they give a consultation appointment with the Dr. Joby. That is 20 minutes to 30 minutes. That's it. In that time, I talk to them. I see that I have an interaction with the parents, talk to the parents, amazing interaction comes there. That could be one of the best way in your local area where you can be the best person by this kind of interaction with them. And that will be the biggest practice booster for any pediatric dentist or any dentist for that sake. Spend some time with the patient. Do not assume or don't think that they are money making thing always. Spend some time with the patient. That can change it.
Thank you, sir. The next question is how much turn we can give on RME?
Oh, that is a different question, Doctor. RME was turning sequence is different depending upon age. Either you are giving what type of thing. It can be 2 turns per day. It can be 1 turn per day. It can be more than that, depending upon that, Doctor.
Yes, sir. So the next question is treatment for lip sucking.
Lip sucking, again, lip sucking and nail biting are 2 habits which needs more than an appliance, which needs talk to the patient. Why are they doing it first? Okay. So, and make them aware. That is what that if you attend that thumb sucking habit of Dr. Binu, this nail biting, this lip biting, all those things is so easy to manage because they are little more psychologically oriented habit. Appliance therapy is the least one. That screening question, that why are you doing this? Keep the lip out first and making them aware would help a long way to break that habit.
Thank you, sir. That was all the questions for today. And thank you again for taking such a great webinar for all of us. Well, we shall see you all on next Sunday. Till then, take care. Good night.
Good night, everyone.